Welcome to the Renal Research Institute's Frontiers in Kidney Medicine and Biology, where we share knowledge and advances in kidney research with the world. In today's episode, we discuss hemodialysis. It is a life-sustaining treatment for kidney patients, and yet, over time, it also can have a negative impact on the human body. My guest today is Dr. Nicholas Selby. He is Professor of Nephrology at the University of Nottingham and Honorary Consultant Nephrologist at the Royal Derby Hospital in England. Dr. Selby is a leading clinical expert on both the hemodynamic and the cardiovascular consequences of dialysis. Nick, you're very much welcome to this series of kidney medicine and biology.
Thank you very much for having me, Peter. It's my pleasure.
Nick, you performed a lot of research into the various effects hemodialysis exerts on the human body, on the patient's body. I was always wondering, hemodialysis is a life-sustaining treatment. So there is a clear benefit to hemodialysis. Now, on the other hand, we learned over the past years that hemodialysis can actually exert negative influence, negative impacts on the patient's body. So what have we learned actually over the years what was surprising, what was less surprising? Can you just say a few words about this, how dialysis possibly impacts the patient's physiology in a negative way?
I mean, the starting point is just to acknowledge that the development and widespread availability now of dialysis is one of the marvels of modern medicine. That's changed in the second half of the 20th century at such a rapid pace to great benefit of many patients. But I think the question about how dialysis can have negative effects on the human body is probably the place to start to answer that question is by looking at how dialysis works and how different it is from your normal kidney function. So all of the time, whether you're awake or whether you're asleep, your kidneys are working 24/7 to filter the blood, make urine, get rid of the waste products of metabolism, and do a myriad of other functions too. But the way that patients receive hemodialysis is not at all like that. It's delivered in intermittent sessions for 4 hours, 3 times a week. So the patient's bodies are not continuously being helped in the way that the kidneys are, but there's these peaks and troughs that happen in between each dialysis session, followed by this intense dialysis treatment. And so what that means then is that things can happen during the dialysis process because everything's happening really fast. You're having to clean the blood in a highly efficient way and also removing excess fluid from the body, the jobs that the kidney would normally do. And what you see during this intense 4-hour treatment time is that this can have great effects on different parts of the body. But what our program of research and many others has been focused on over the last few years is how this then affects the blood flow to different parts of the body. And there's good evidence now to suggest that dialysis causes reductions in the delivery of blood to critical vascular beds. And by doing so, and on a repeated basis, 3 times a week, every time the patient comes for dialysis, that can have negative effects. So it's life-saving, but it's not a perfect treatment, and it can have adverse effects on the human body.
I'm very happy that you put this question into the framework of physiology, of normal physiology, and pointing out that in kidney healthy subjects, the cleansing is going on a continuous basis. And so you're saying it's really this intermittent character, the fact that solutes and fluid are removed within a very short time frame, say within 12 hours a week, which is around 7-8% of the week, instead of 100% of the week, that this is really the root cause of these negative effects, right?
Absolutely, and I think later on in the conversation we may well circle back to that very point, but just to give you a sort of an example, we know that transplantation is often the gold standard treatment in many patients, and by having a kidney transplant you go back to having that 24/7 kidney function that you clearly don't have when you're on dialysis.
So, Nick, are there actually certain organs that are particularly affected by this repetitive loading and unloading? And if so, what organs would that be, and what would be the clinical consequences of this reduced perfusion of those organs?
Yes, there are, and I think there are differences between organs, but also differences in how much we know about the different organs. And the place to start is the heart. We've known for several decades now that patients on dialysis have significantly worse outcomes in terms of their cardiac health, and they're more susceptible to heart failure and more susceptible to death from cardiac causes. And that's got many causes, and you're right, there's a direct effect from volume loading and then unloading, and that sort of repetitive nature which isn't good for cardiac function. But if we focus in on the effects of perfusion, then really it was the heart that this process was discovered in first. And what we know is that blood flow to the myocardium, so the heart muscle, falls during dialysis. And in tandem with that, we also see changes in how the heart functions. And so there's a reduction in cardiac function during the 4-hour dialysis treatment. And research has also shown that when that happens on a repetitive basis, so every time the patient dialyzes, over a longer period of time, say after 12 months, patients who are being affected by that process end up with fixed long-term reductions in cardiac function. And then that becomes a very serious situation, because that is the scenario where patients are more vulnerable and at higher risk of having a worse outcome. So the heart was where it was discovered, and the heart is where it's been studied the most. That being said, I think there's good evidence now to show that the same process happens in other parts of the body. Probably the next most important, and maybe most important in terms of symptoms and what it means to patients, is that the same process also happens in the brain. So blood flow to the brain changes. We can see, using very detailed MRI scans of the brain, that certain areas of the brain in dialysis patients become affected by ischemic change. And what I mean by that is changes due to reduced blood flow. And those areas of the brain are often those that are important for higher executive functioning. So those very tasks that we need to carry out our daily lives are being targeted by this process. So straight away you can see that's really important for patients, and also contributing to cognitive decline. And then other areas of the body, I think we also think are very important, are residual kidney function. And that might sound a bit strange, because these patients have got kidney failure. So why do we worry about their kidney function anymore? But the answer to that is that those patients who've even got a little bit of kidney function left and still making a little bit of urine themselves, that's really helpful to their health. And if you lose that more quickly because of this same process happening in the kidneys, that is also a negative consequence. And then possibly some evidence around the same process happening in the gut, and maybe the skin, which is relevant for patients with diabetes, with foot ulcers, for example.
So it seems that there's a wide range of organs, of vital organs, really affected by those by this reduction in perfusion of blood flow. Say, Nick, are there certain patients who are particularly vulnerable to the effect of hemodialysis on the hemodynamics?
I think that's a great question, and I think we know some things about the answer to that, but maybe I think there's also more to learn. I think there are some patient-related factors that might increase the risk, and then there are some factors that relate to how dialysis is delivered and how patients are getting on with their dialysis in terms of making it work for them. So patients clearly that are more at risk are those that have vascular disease, diabetes, that type of thing. But then on top of that, the elements that are related to dialysis are those that tend to make it more of a stressor on the body. So bigger changes in blood pressure, taking larger amounts of fluid during each dialysis session are two key factors that we know that are related. But that doesn't explain it all, and some patients still exhibit these changes even without those factors, and we're not always 100% sure that we're confident in predicting which patients this is happening to. So I think we know part of the answer to that, but I think there's still more to be discovered.
You were focusing so far, and we were discussing so far, the hemodynamic impact, the impact on blood pressure. There is some patients who are particularly prone to a dramatic reduction of blood pressure during dialysis, in what's called intradialytic hypotension. Do we see the changes you just described in brain and heart and gut and skin and residual kidney function? Are these all predominantly observed in patients who actually experience intradialytic hypotension, or are those seen also in patients who do not have intradialytic hypotension?
And it's a great question, Peter, and you logically think that the patients that you've described are the ones that this process is happening in, and I think they're clearly the most vulnerable, and the answer is that it happens more often and to a greater severity in those types of patients. And I think the symptoms that those patients experience, both when their blood pressure drops, but also in how long it takes them to recover after dialysis, it links in that they're the most severely affected. That's for sure. But you also see changes in organ perfusion happening in patients who don't exhibit such dramatic changes during dialysis. And then really intriguing data shows that some of these changes can be detected quite early on during dialysis. So it's not just a change in blood pressure per se, it's more complex than that. That's why I think we haven't totally characterized which patients this happens in. We know which patients are at greater risk, but it's still happening undetected in other patients that we can't currently identify at the bedside.
It's interesting that you talk about those changes that happen early on in the treatment. I mean, with dialysis, blood touches non-physiological surfaces, the dialyzer, the blood lines. Do you think that this interaction of blood with those non-physiological surfaces can play a role, particularly in these early changes?
I think it's, again, a great question, and I think that's a hypothesis to be tested. So you could certainly construct an argument by which that contact of the blood with the artificial surfaces triggers either clotting or inflammatory processes. And we know very well from other disease areas, for example, sepsis, where you see activation of those pathways, you see changes in blood flow at the microvascular level. So some areas where blood flow increases, other areas where it disappears. So you get a mismatch and a disorder of blood flow at the microcirculatory level. and that's disconnected from what's happening with blood pressure. So it's a hypothesis, I think, that needs to be tested, because you can certainly make a scientific argument of why that's plausible.
Thank you, Nick. And there are also many other things that happen when dialysis is started and during dialysis. I'm thinking, for example, that certain solutes, say urea, for example, where there's a high concentration in the patient, are removed rapidly from most of the body, but not from other parts of the body, like the brain. In the brain, there is a delay of urea removal from the body, so from the organ. So I'm wondering to what extent do you think this could play a role, say, in impairing cognitive functions in patients? Because with urea sticking longer in the brain, this could cause brain swelling, for example. Do you think that this may have an effect on impacting, say, cognitive function in patients?
I do, and I think there is some, not a lot of evidence, but some evidence over the years that sort of supports that. And we've recently completed a research study that would also support that premise. So we saw changes in brain volumes, for example, that were unrelated from changes in blood flow and perfusion. And linking that to a sort of an accelerated aging process in the brains of patients with dialysis could be a new way of looking at hemodynamic stress on that really critical organ, which is clearly so important for symptoms and well, yeah, obviously for everything, but for activities of daily living in particular. So yeah, I do accept that.
So this is very interesting, and we did some research where we measure urea levels in the cerebrospinal fluid before and after dialysis, and we see different dynamics there. A patient where it would go in parallel with the blood urea levels, but in others it would stay almost constant. And then there are differences in psychological tests of those patients. So it's a very very limited experience. But I was really wondering if these osmotic shifts that may be induced by urea staying for a longer period of time high in dialysis patients could actually contribute to damage. And I'd be so interested to learn more about the study you did on brain volume.
Absolutely, and you're right. It's the rapidity of change, isn't it? And the way that we deliver dialysis, it's everything is done at maximum efficiency. So that initial change in the concentration of different solutes in the blood is very rapid.
Yeah. And I mean, it's not just urea. I'm thinking like potassium that's removed rapidly during dialysis. Patients arrive usually with elevated potassium levels, and then it's reduced rapidly, which may affect conductivity in the heart and others. Do you think that this could play a role with respect to long-term changes? Is more an acute effect where people have to be concerned about, say, arrhythmia?
I think for potassium, I think it's probably more acute effect, and that sort of links into the sort of arrhythmias that you see during dialysis, and that link to sudden death, which is more frequent around the sort of that long gap when you have a 2-day gap between dialysis sessions rather than just a 1-day gap. So I think I'm struggling to see how changes in potassium would have those sort of long-term effects as clearly as some of the other mechanisms.
Yeah, other electrolytes that come to your mind, such as, for example, sodium. That the sodium that is removed from the patient, or possibly even loaded to the patient during dialysis. Do you think that this is part of this complex of intervention that would affect patients' physiology?
Yeah, absolutely, and we know sodium is important, really our understanding of sodium has changed a lot over the last few years, with some really inspirational research that's been done, particularly by Jens Tietz, but also others, using new ways of imaging sodium. So I guess traditionally we thought about sodium as the sort of predominant extracellular cation, so it's linked to how much fluid and water is in your body, and that sort of links into what we're saying about changes during dialysis. And I think the relevance of sodium is separate from urea or potassium. It's something that we might be able to change and modulate more easily with dialysis, and that's why it's so interesting. But some of the really interesting research around sodium has shown that there's actually storage of sodium in places in the body that we didn't appreciate previously, and it's stored in the skin and in the muscle, separate from water, which is really fascinating. And there's now questions about what that sodium is doing, how it can be changed and manipulated. But it's relevant because it links to blood pressure and possibly cardiovascular health. So linking that to how we handle sodium during dialysis, I think, is a very, very pertinent area that we need to see more research in.
Yeah, clearly a new area, and we just have to learn so much about this. Now, but this brings me a little bit to what can we do actually to reduce the impact of hemodialysis on the patient's physiology. So I believe it was really one of the first papers I read with you as the first author about the use of cool dialysate. You performed a meta-analysis, and this paper of yours and together it was just together with other data on this. I mean, it was just such an eye-opener. Could you say a few words about what can be done to mitigate those effects of hemodialysis?
Yeah, definitely, and I think probably I'd sort of answer that question in terms of sort of two blocks really. The first is, what do we know about interventions that have actually been shown to lessen that effect of reduced perfusion to organs? So actually studying the effect of dialysis on organs and looking at the benefit of an intervention. And then there's a sort of a second question about what evidence do we know about making dialysis more tolerable? And there's some links there across those two sort of different parts of the question, and some maybe that's a little bit more common sense. But in terms of the interventions that we've got evidence that improves the tolerability of dialysis and reduces that change in blood flow. So a fairly complex intervention called biofeedback dialysis, where the machine senses changes in blood volume and then automatically reacts to that to try and reduce hypotension. And some of the early work that I did under the supervision of Chris McIntyre showed that approach had a benefit, but it's hard to take that into the clinic. It's a bit too cumbersome. And then cool dialysate, which we've known the benefits in terms of its effect on blood pressure since the 1980s. We then became interested in that because it's much easier to apply and it's effective at reducing blood pressure. And we were able to demonstrate that it reduced the changes in cardiac function during dialysis, so it lessened the effect there. We showed that it was able to, it had less of effects in terms of reductions in blood flow to cardiac muscle. And then an important study done by a colleague called James Burton, but also under Chris's supervision, showed that the long-term effects of cardiac function are equally important on patient health. So a randomized trial that then followed demonstrated that cooling the dialysate actually protected cardiac function in the long term, and the same process in the brain. So cooling the dialysis affects the short-term process, and it also provides long-term organ protection. So So that's what we know. The second question is about how can dialysis be made more tolerable in general, and so in addition to what we've said, there are other ways of trying to reduce drops in blood pressure, but the approach that might be effective but not always welcomed by patients is to increase the time that dialysis is delivered over. So it's more gentle and not as rigorous. Or to dialyse more frequently. So instead of doing 3 times a week, you might dialyse 6 times a week. And actually, we've got quite a big home dialysis program at our centre, and that it not just has those benefits. Patients, you can see that their symptoms are much better, and you can imagine how dialysing overnight for 10 or 12 hours 6 times a week is very, very different from short intermittent dialysis, sort of 3 times a week. And finally, peritoneal dialysis, so a different modality of dialysis. We know that doesn't cause the same hemodynamic effects and end organ damage in the way that intermittent hemodialysis does. So I think there's a range of things that can be done, and individualizing that is quite important.
Yeah, I think you bring up this important point about home dialysis and how well patients are actually doing when dialyzed, say 6 times a week at home. I mean, this will take some time to evolve, but we see tendencies that the numbers are increasing. I'm wondering, what are your thoughts about just getting rid of this long interdialytic interval? So as patients are dialyzed, say, Monday, Wednesday, Friday, and then the next is dialysis is on Monday. What if this interval would be reduced, say, to 2 days? So it would be a dialysis every other days in those patients who are in center. And I know there may be tons of logistic problems, but what do you think in principle about that?
In principle, it makes sense, doesn't it? We know that long gap is associated with excess fluid accumulation, it's associated with higher potassium levels on patients coming at the next dialysis, and it's associated with higher rates of sudden cardiac death. So it makes sense, but whether the logistic barriers can be surmounted, I think, is a big challenge. So I mean, I don't know how you see that question, Peter. It sounds simple, doesn't it, to dialyse alternate days, but it's not. People have a routine, and changing that's very difficult.
Personalized medicine, I think, is really gaining a lot of ground. So, how would you stratify patients for a specific treatment? So, would you use traditional, say, clinical acumen? Would this be supplemented by certain studies of the patient's physiology, by biomarkers? How can you give us some insights how actually to advance the personalization of the patient's treatment?
Sure, I think we do it a little bit, and it is mostly based on clinical acumen, if we're going to be honest at the moment. So if somebody is approaching dialysis, they're choosing which modality they're sort of planning for. If somebody's got very bad cardiac function or low blood pressure, or they're going to be at risk of having hypotension with intermittent hemodialysis, those considerations need to be brought into the shared decision making, and that might be a factor that swings the choice towards peritoneal dialysis, for example. So I think we're doing that type of medicine already. Going back to what we said before, it's actually difficult to fully provide personalised medicine in this area at the moment, because we're not good enough at detecting which patients are sustaining the process. And most of the tools that we've used to identify patients, they've used research grade imaging techniques, quite specialized at the moment, not immediately relevant to clinical practice. So we have to bridge that gap and take some of those methods and bring them a little bit closer to the bedside. You mentioned biomarkers, which are sort of blood tests, and again, they're not the perfect solution. So they give information at a population level, but when you're actually trying to evaluate an individual patient, they're not good enough to tell us what to do yet. So maybe we need to sort of get a little bit more creative. I know you've done some fantastic work around monitoring oxygen levels in venous blood, for example, which might be a way of gaining some insights into the hemodynamic response to dialysis. We are focusing at the moment on approaches to non-invasively monitor blood pressure continuously. And if you get that really close resolution of blood pressure changes, that might be a way that then you can apply machine learning or even predictive algorithms to say, okay, blood pressure is about to drop. Let's do something now before that happens. And we don't do that at the moment. We've got a blood pressure cuff that goes off every 30 or 60 minutes, sometimes less. And I think getting a tighter grip on blood pressure monitoring might be a way through.
Yeah, we are almost coming to the end of this really interesting conversation. Nick, maybe 2 or 3 sentences. What would you want the viewer, the listener, to really take away? What would be important points you would want to communicate to our audience as a sort of summary?
So I think the first thing is we sort of focus a lot on the adverse consequences of dialysis, but let's go back to where we started. And actually, dialysis is an amazing treatment. And my sort of first take-home message is actually by concentrating on dialysis and attention to detail and delivering it as well as we possibly can is likely to have benefit to patients. And that's a move away from a sort of a conveyor belt approach, which we've sometimes seen in the past. And then I guess the sort of the second point is actually thinking about personalized medicine. What we need to do is be able to not just understand physiology, which we're starting to do a little bit in the research setting, but we actually need to be able to measure that in clinical practice. And until we can sort of get a handle on that, then we can't really sort of improve the way that we prescribe and deliver dialysis at the moment. So understanding and measuring physiology will allow us to sort of move forward in terms of treatment improvements.
This was such an insightful conversation, and I think it laid also out in what direction we need to go in the years to come. So, Nick, Dr. Selby, thank you so much for spending half an hour or so with us and with the audience. And I'm, of course, looking forward to outcomes of your research in this really important area. Thank you.
Oh, well, thank you for having me. It's been a great pleasure talking to you. Thank you.
Thank you for joining the Renal Research Institute for this episode of Frontiers in Kidney Medicine and Biology. We invite you to engage with us on our social media channels and look forward to seeing you again for the next episode on Frontiers in Kidney Medicine and Biology.